I don't even remember.
All right, everyone. Thank you for joining us. Please be advised this meeting is going to be recorded as a public meeting, and then we'll post the recording on YouTube. So anything said or visually captured has the potential to be shared. And then the chat message too. Dr. Gager, I think.
All right, let's go ahead and call the meeting to order. The first order of business is roll call.
Allison Welch. Ariel Moreno. Barb Stolpa.
Present.
Candace Williams.
Present.
Mary Wood.
I'm here.
Corey Usher.
Present.
Dale Woolridge. Dan Otto. Dale on the line. Is he online? Dan, can you please chime in when you get your audio fixed? Oh, Dale.
Yes. Dr. Woolridge, are you, I think I see you trying to speak up there.
I am. I was muted. Apologies. I am here.
Thank you.
Thank you. Sanford Kick.
Present.
Darth Gamer.
Present.
Heather Miller. Josh Gaither.
Present.
Julie Augenfink. Laura Smith. Maria Sala. Maria, can you chime in verbally when you get a chance, please? Michelle Guadnola. Paul Dabrowski.
Here.
Ralph, Dane Kelly. Dr. Kelly. Ray Troa. Shanna Cloughs. Shanna, when you get a chance, please chime in verbally. We see you online. Sean Bowker. Phoebe Merrill.
Present.
Tiffany Streever. Yeah. Tiffany, chime in verbally, please, when you get a chance. And then Tom Flanagan.
Present.
We have 16, so we got 4.
Good morning,
Thanks.
Shelly. This is Maria Sala.
Great. Thank you very much.
Awesome. Thank you all for attending today. We'll start with Chairman's report. The first thing, as always, is our attendance report. Please take a moment to check your attendance. As a friendly reminder, you can, of course, attend in person or online. The Bureau will send you a reminder of the importance of you attending if you miss more than a couple of meetings. We do have one vacancy also that we are still looking for someone to fill. This is a rather difficult spot. This is for a law enforcement representative. The law enforcement representative must have active involvement in EMS to fill that role. I know these are few and far between, but if you know an individual who would be interested and available to attend meetings, important, please pass their name along to Shelley and we'll get them on the agenda to be approved.
Can they be active law enforcement or could they be retired?
I suspect this is active law enforcement. I'll defer to the Bureau for clarification.
I think based on the, how it's listed on the kind of list of participants with the active involvement in EMS, I think they have to be working still.
Because I have a guy who's retired as a captain, police officer, and is now becoming a paramedic, so that's why I'm wondering.
Yeah, I suspect under this one, it would have to be actively working.
Yeah.
Mostly because the purpose of this committee is to do data analysis, reporting, to get that active involvement.
Thank you.
Thank you. With that, I'll turn it over to the Bureau for the Bureau report. Dr. Brett.
All right, thank you. I will do my best to fill in for Chief Garcia, who is out of the office. So we will go through just a little bit of abbreviated slide sets, just some bureau updates for the day. So still kind of top priorities for the Bureau for 2024. Some of our big assessment that we've been working on in the last year is the EMS and Trauma System Needs Assessment and Strategic Plan. We've had really great input from multiple parts of the state, and we'll have a strategic planning session working on that moving forward. Also continue the rulemaking focused on EMS workforce development and training, procuring the new Arizona State Trauma Registry, continue to promote time-sensitive illness and injury programs such as share and unlock the leave behind, and then also work on alternative destination guidance with emphasis on behavioral health. Next slide, please. So this is a timeline and kind of update of our strategic planning process. So with this process, we've had the listening session, the learning, we're learning. Planning and prioritization, which is going to be our next step, and then ultimately implement the actual plan, which will be from January 2025 through the end of 2030. Next step, please. So this is where we are currently. So we are finalizing the results of our needs assessment report, including developing a regional and county profile. In April, we're going to be hosting an EMS Common Strategic Planning Summit. In September, we will have a draft strategic plan that will be shared with EMS Council staff for approval. And in November and December, the goal would be to publish the strategic plan for the goal of start implementation of January 2025. Save the dates. This is the upcoming strategic planning summit. This is going to be April 10th, 2024. So this will be held in person here at ADHS from 10 a.m. till 2 p.m. Lunch will be provided. We have quite a bit of information. So just a reminder, we do have the EMTP of the Year Awards here with our first year that we awarded these. So this will be our second year of doing these awards. In addition, we will have the Trauma Center Awards. We'll go through these. We have extended sorry, that's okay. We've extended the time frame to get the kind of nominees in here. So the nominations are until the end of this month. So we wanted to make sure we got an opportunity to just remind everyone at this meeting, and then there's an additional 10 days to get those nominations in. The EMPT of the Year's Award, there's a number of factors here. There have been nominations that have gone out. If you need any information, let Shelley know and she can get you any links to that. The new one this year is the Trauma Center Awards. We are really excited to implement this. This is going to be a new award that will go out during STAB. So that will be in May. And there's a number of different nomination categories that's outlined on the slide set. So if you're interested, this will go to kind of a stakeholder team that will do the awards for the trauma centers, and those will be announced in May. Just a brief rulemaking update. So completed rulemaking updates have been EMS scope of practice was 2022 last was the last updates. Air ambulances went live in 2023 along with trauma center rules, limited updates to those, and ground ambulance rulemaking just completed in 2024. The two pending rulemakings currently are EMCP certification and training, and then ENCP scope of practice. The ENCP scope of practice will be to specifically address the EMR addition as well as the critical care endorsement. And we do have a joint PMD and NNCP meeting that I believe is May 1st to address those. The next step of the rulemaking process is we are having work groups for meeting sessions to look over these. We just had one last week regarding critical care paramedics and emergency medical responders for ambulance drivers. So those are in process. And then interfacility transport reporting requirements, including department approved format for submitting performance assessments. So this is kind of the next two that will be in process. Any meetings will be sent out by our GUP delivery. So if you are not yet signed up for our GUP delivery system, please sign up. That's where you will get notification of upcoming change. The brief additional state and federal updates. So just an update on our SHARE program. So we are completing our transition of the AED and CEDAR registries from the University of Arizona to ADHS. The new AED registry site is live as well as the new CEDAR registry. So those are both live on our website. The point of contact for that are Julia Vinton and Adam Rodriguez. So if you have any questions or need to get access to those. And we are in the process of just updating all of our documents related to the SHARE program. Oh, that might be awesome. Oh, no. And then a lot to leave behind. Really excited with the success we're having with us already. Currently, we have trained 2,139 EMTs and paramedics in the state of Arizona. So that is a really big number. So I'm really excited about that. We have 29 agencies that are participating in the state. We have shipped 1,336 kits and 99 tags scanned. The 99 tags scanned means that when the EMS provider have given them out to an individual, they've actually scanned the QR code and inputted their unit and zip code for what that's given out. So we anticipate that likely kits are being given out without that scanning occurring. But the fact that we have 99 kits that have been scanned is a really good start. So excited to see that. If you have any questions, Dave Hanson's email address is on the slide and you can contact him regarding that. There are also some new naloxone saving lives campaign that ADHS has published. You can see the link here. We'll make slides available after the meeting if anyone's interested. But this is one of the big campaigns that the department is focusing on to help address the opioid epidemic. National Registry updates. Just a reminder that there will be a representative National Registry at the Education Committee meeting at 10:30. If you have any questions about that. One of the big things we want to remind everyone is the psychomotor test is going to sunset on June 30th, 2024. So for anyone who's currently in a program as of July 1st, if they have not completed their National Registry exam, their new exam will be the new format. So we had a meeting with National Registry last week. It does not appear that there will be any extension of that time frame, so that is a very hard switch when that switches over. So if you have students that are finishing in June and they're not ready to necessarily try out the conversion, encourage them to take the test before June 30th. The 2016 NCCP model goes through September 30th of 2025, and then there will be a new 2025 model that will expire after March 31st, 2026. They've had a number of recent resolutions, which you can click on from this document if you apply this afterward. And they're also doing some studies looking at workforce development and occupational risk. In regards to the trauma registry update, I think we have this later on the agenda for Chris to cover, so I will let her cover that later on. Just a quick reminder, we will always like to share the work that our DQH team does in terms of the trauma and EMS dashboard, and we'll just continue to highlight those as well. And I think that is it. All right. Next, I just want to welcome several new Bureau staff members. So first want to welcome Kara Martin, our new DON auditors, Dave Higginson, who is our FR Kara grants administrator, Mike Hamilton, who is our senior GIS analyst, Mitch Adair, the new investigator, and Jeff McGrath, another investigator who have both joined our enforcement team. I have given the update regarding the lead behind. Let's see if there's anything else you'd like to add. Okay. And like I said, we're having a really great success getting people involved. If your agency is interested, there's links on the website, or you can reach out to Dave directly. And I believe quickly you are on the line to do the trauma data registry RFP process discussions.
Yes, good morning, everyone. So we are still in the process of working with our procurement department to put together our RFP. And once that is out, then our vendors will be able to place bids for our new registry system. The goal is to have that done and to have a new registry system contract by July 1st of this year. And then between July 1st of 2024 and July 1st of 2025, we will work on implementing the new registry system as Trauma One is sunsetted out. So those are the updates for now.
Thank you. Any questions for Carissa? Next, I'll hand it over to Julia.
Dr. Bradley already really gave a summary of this, but just to emphasize, we do have our strategic planning summit on April 10th, and we're hoping to kind of use that time to go through some priorities and look at objectives to include in strategic plan. So I believe all of the committee members should have received the calendar invitation. So if you're interested in participating and would like some more information, please feel free to reach out.
Thank you. Next up, Lawful, I believe I see you on the line as well for an update. Regarding the
Yeah. Good morning, everyone. We had a trauma manager workshop meeting last month, and Arizona Department of Game and Fish came over to give a presentation on the Quail Kids program, kind of a training for the ATV education program. It was a very successful training. And followed by that, banner on our website, we have actually put a notice also that on June 20th, Banner Ironwood Medical Center will be hosting a Quail Kid outreach program based on the training received in that trauma manager workshop. So any hospital who is planning to now implement the Quail Kids in their community, please let us know. Either I or Carissa, please contact us so that we can give you guys the evaluation for the program. And also, we can put on our website the announcement for the upcoming Quail program event. That's about it.
All right, thank you. Any questions for Rothel? Next, we'll go to updates from user groups for Trud, Maria.
Good morning, this is Maria. I just have a couple updates. Our next data submission is due April 1st. Carissa is teaching us, or whoever's interested, on report writing on our meetings, on our truck meetings. We also went over our inter-facility definition for urgent care facility. All patients coming from urgent care facilities do count as a healthcare institution if they come by EMS or ambulance. And that's all from the truck group.
Thank you. I'm just going down, Josh. I'm gonna hand over to Josh.
Totally fine. Heather, you're up next. Trauma Program Manager Workshop.
Yeah, so Bethel kind of covered the main thing. Arizona Game and Fish did that HOV training and Quail Kids. We also did reviewed the strategic planning and had some pediatric trauma education. And then our next workshop should be coming up in the next couple months. I don't believe we have the date finalized just yet.
Thank you, Heather. I know Ray is not here today. We have someone else to do it.
Yeah.
Oh, did you join? Oh, perfect. Sorry, Ray, go for it.
No worries, no worries. So the only thing I have to report is this: the actual EMS registry group user meeting is on the 28th of this month. It's next week, 10 to noon. So if anyone's interested, other than that, I believe there were some emails sent out. If anyone was looking to revise some facilities and codes and things like that, I believe those were put out over the last couple of months. So if you've got those emails and you have some new facilities, feel free to go ahead and get those and send them back in, and that way they can get added to the registry list.
Thank you, Ray. All right, let's move on to discussion and action items. First thing on the agenda is to review the draft meeting minutes from our November 16th meeting. So I'll look for a motion to approve those, and then we can discuss as needed.
Heather, motion to approve.
Thank you. I think we just have a phone number. Did you get names of those, Shelley?
I heard Heather and Garth. Is that correct?
Yes.
All right, perfect. Any discussion on the draft meeting minutes? All right, hearing none, we'll call for a vote to approve. All those in favor of approving, please say aye.
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 Any opposed, say nay. Any who wish to abstain, say aye. Thank you all. The draft meeting minutes are approved without any revisions. Let's move next to discuss and approve the shared data elements for PEEP status. I need a motion to discuss the new shared data elements, and then we'll share those and discuss. Do I have a member that would be willing to do that as a motion?
This is Ray Pro. I'll make a motion.
Thank you, Ray. Second?
Gamer.
Thank you, Garth. Shelley, do you have the PEEP?
I thought I did. I will.
Well, that's coming up. I'll give a little bit of background on this. So one of the things that we have been trying to do as we transition the shared cardiac arrest data from the University of Arizona back to ADHS, it's really attempt to modernize some of the data. Really, Arizona became a leader in cardiac resuscitation under Dr. Barbara's leadership with input from the stakeholders many years ago, based on, at that time, it was primarily written record. And over time, the last 15 plus years, we've converted to electronic patient care record. We've got now ways to share records and data much more effectively. And so the ability to start kind of manually going through every chart, as you think about the number of cardiac arrests in the state of Arizona and how we can actually document these things, we wanted to look and see if we could start considering making the cardiac arrest elements a component to be a premier EMS agency program. So typically what we would do when we've made any updates to the premier EMS agency program is we've brought the data elements to this committee, have this committee weigh in as the data experts to see if they feel like these are good elements and kind of a reasonable one for the EMS providers to document. And then that would go to EMS Council to vote on to decide whether this should be a criteria for being a premier EMS program. So you can make it a little bit bigger just for those in the room on the screen. And you will see here, one of the changes that did occur is with the EMS 3.5 conversion. Hold it up, thank you. Once they did align the CARES registry, which is kind of the National Cardiac Arrest Registry, with the EMS 3.5 data element. So that was one of the big changes that had occurred. In the past, the previous version, the EMS data elements did not necessarily align with CARES. While we are not a CARES state in Arizona, our data elements really being pretty much the same, cardiac arrest outcome elements. And so with this, the new EMS 3.5, as everyone in the state has converted over, we are looking at these in terms of making things kind of elements for that. So if you can see here, you see the EMS element on the left, the AZ peer status, whether it's required or optional, the EMS status, and if you go over just a little bit to the right. And then just whether or not we recommend it for peak. So that's kind of one of the things we want to do. So if you look down here, you can see under the one element that's still there is therapeutic hypothermia, which is really no longer recommended. So that is optional both for AZ peers and NEMSIS. So that's something we could consider just kind of striking completely if we wanted to. And then if you go down a little bit further, one element where you see a little bit of difference between, if you look at arrest 15, that's date and time resuscitation discontinued. And we have that as required, it's recommended for NEMSIS. And then ERS 19 is daytime initial CPR. We have recommended and it's optional for NEMSIS. And then we have 3 at the bottom, which are custom elements in the NEMSIS data set. And so they're kind of duplicative. We have those really covered above in our other elements. Defibrillations covered previously. We have rock time. If you have rock discontinued compressions covered in other data elements. So we have that. And then I think also we had the table that shows completion rates. I think that was, yes. So we can make this one a little bit smaller. So this, and I may need you to just, if I misspeak in any of this, please correct me. But these are the current data elements and the percent completion rate. So you can see now kind of what the current completion rate is without us necessarily going out and making this a big push. So as a baseline, many of these actually look very good. So you can see the cardiac arrest etiology, resuscitation, arrest witnessed by, AED use, type of CPR, first rhythm, if there's any rock. Many of those are very high scores. There's obviously opportunities for some of these, and you can see what are the lowest scores is ERS 15, which is an optional NEMSIS one. So we wanted to kind of share this information, open this up for discussion to the group to see, number one, does the group feel like this would be a useful thing to have as a requirement to be a premier agency program? The thought process about this is if this group approves this, we would take it to EMS Council in May. If EMS Council approves this in May, that would really allow agencies from May until the end of December to kind of train, make sure they have these as kind of required elements in their CPR system with a goal to kind of go live with data collection in January of 2025. The hope is that this would really streamline our shared data collection from the EMS agency side, which would be a huge benefit. So that's kind of a little bit of the ask and the potential timeline is group thinks this is initial.
Thank you. So we'll open it for discussion, feedback from the group. Anyone have some items individually you'd like to discuss? And I think we probably specifically discussed the recommendations for no. But before we get to that one, items you'd like to specifically speak in favor of or against? Dr. Ray.
Yeah, I think it would be a great idea. Looking at the elements that have a lower score, I think that they are things that are probably pretty important for cardiac arrest tracking. So I think just like making them a peak requirement would improve that and improve the share data. So I think even just that alone is a reason to do it. But I'd get to work with it for sure.
Thank you. Others?
Maricopa Ambulance, I have two operations that are essentially BLS 911 operations, and filling in that stuff for the EPCR when we're using Fire's ALS chart as our sort of billing thing is difficult to get EMT basics. That's kind of my fight right now internally, is getting them to fill out those cardiac arrests. How does that work? Any of those low scores are probably my BLS kids.
It would be the transporting agency that would provide this data, correct?
We get it from anyone who does the EPCR. So we would typically with you, depending on your response model in the state. So with some response models, you may have a single EPCR from the initial responding and transport unit with the same agency. Others, if you have a joint response model and you have a fire apparatus and then a separate ambulance service that's not the same entity, you would have essentially two reports for the same call.
Right.
And that,
But presumably that data is still getting captured.
Yeah.
Right. Just because they're the BLS provider doesn't mean that they're not able to capture this for the entirety of the call.
So there's fields in there like asking for rhythm interpretation, those sort of things. But it's not their scope.
Yeah, in rhythm interpretation, it also includes whether or not it's an AED shockable versus not shockable. That's included.
I guess what is my BLS crew goes out, ALS fire crew goes out, and firefighter, paramedic jumps on my BLS ambo. Trying to make that a thing for my BLS kids to document a code when they don't understand half of those fields. That's not what they're trained in. That kind of becomes a problem for us.
Is the ALS provider not documenting their own care?
They document their care and then bail out. Our guys aren't left with even a copy of their chart. It goes digitally through the system and back around to someone in billing that attaches it.
so I was gonna say, in terms of the data elements for Premier EMS agency programs, this would be like your overall tool for your entire entity. So it's not gonna be, you kind of look at this from the entire state of how many calls your agency runs, what % of those are going to be run by the DLS only that are cardiac arrest. So I think that's, it's looked at as the entirety of your call volume. It's not just based on that contract, if that makes sense.
Yep. Thank you.
Thanks for the discussion. Other topics? I think the one question for the group is, does anyone see it as important to keep in those that will be excluded or proposed to be excluded? Hypothermia, I'm certainly comfortable excluding that one. I can't remember what the other one was. There's two, correct?
Hypothermia was one of them that was optional for both. And then there's ERS 15 and ERS 19 that are different between what we have in safety peers versus BEMSTS. So those are kind of two other ones to look at.
So 15 is, ERS 15 is time and date of CPR and discontinued. And 19 is time of date of initial CPR. Seem as important data fields to me, but
Yep.
yeah, I would vote to include those is my feeling, but
Recommended maybe?
yeah.
At least recommended.
Dr. Gaither, this is Ray Pro for my fire. I'm also therapeutic hyperthermia. I'm good with that staying. And then as far as all the other data fields, if you're like as far as the way I see it, if you're looking for that to be a premier EMS agency, most people are following probably the 10 things from Resuscitation Academy or an ACR kind of bundle of care, and they're tracking those anyway. Especially if you're looking to kind of, in my opinion, kind of be at that level for cardiac arrest. So I'm good with the way they stand.
Thanks, Ray. Other thoughts? All right, any other discussion on this? I think the sentiment I hear in the room is that the motion to approve this as presented by the DHS with no recommendations is the motion on the table.
Well, I think it's for first to kind of discuss, do we want to include the substantive elements and then I guess looking line by line, if there's any that we want to essentially adjust, we could do initial motion and then a friendly amendment.
I think we have a motion. Oh, maybe.
Yeah, we do have. some
Yeah, we do have a motion to approve this, and then are there any friendly amendments to strike a line or change otherwise that is not there? Matt, do you have your hand up?
I said a question maybe for Ann would be better, but for QREPS 14, will the state accept unknown as a, it's often that we'll get on scene and when there's an unknown downtime, so time of arrest is not possible. So will unknown be an acceptable thing to a data point?
This is Ann, sorry. I need to check what the value options are. I can go in and check really quick, but I do know that the definition says if unknown, please estimate. I realize not everyone loves that. I believe they're going to make some changes in the next version to potentially add something where you can indicate that it's an estimate specifically. But yeah, let me check to see what the options are that NEMSIS has in their values.
I would be uncomfortable with estimate. If unknown is much more reasonable if possible.
And I think with this one, if you look for the completion rate, we're at 57.7%, probably for that reason. When you look at this, we would be combining all the scores. So, you know, if there's one data element that you're lower on, but everything else is high, I think it would average out.
It'll be bad data coming in, right? If we're just guessing the time.
Yeah, and I think that's the issue is that it's defined properly, so you could estimate, and it shouldn't be bad data from that point. But how that was our argument with the other states. That was our point nationally, was that it's really nice to know if this is an estimate or the actual one. There is a last known well. I know it's not on this list, but that is how they've addressed it in the past. Is with some of the time-sensitive illnesses, and I don't believe this was one of them that in the past that we've accepted it based on the importance of it. But with some time-sensitive illnesses, we have looked to see if the date, time, you know, of injury or whatever is missing, is the last known well filled in? Because that is basically saying if the last time someone saw them was the night before, then you fill that in instead. So if the committee feels like that's an acceptable option, that's something we do collect.
Never seen them fill that out for that
Last known well.
on a cardiac arrest.
Yeah, I don't know the last known well is helpful.
I mean, any unwitnessed arrest, technically unknown. I think you could. I don't know, there's no way to-
And in the short term, I don't see any way to fix this. It is it's the system that we work with, and it is important to know from a data and system performance perspective, if there was a time at which the cardiac arrest occurred, we need to know that. So if we have to guess, I think guessing is, in my mind, better than not getting the important data point on the ones talking about.
And another option is, I think what we do with in the past with some of the validation rules, which is separate from what this is. We have done something where, so the options off the top of my head for the cardiac arrest are now it's prior to any EMS arrival, after any EMS arrival, or no. Okay. So for the ones where it is after EMS arrival, we expect this to always be filled in because if somebody was there, somebody should know. If it was prior to EMS arrival, I believe we have in the past said if it's witnessed, and someone brought that up. So there's a field also on here, arrest witnessed by. So if it's a prior and it's witnessed, then we expect that to be filled in. But once again, it depends on what this group, wants to default towards, because the more of the kind of caveats you get into, then if they didn't fill that in, are we just going to be missing it for an agency for almost every single time if they don't ever fill in the witness by properly? You see, it's like a waterfall effect.
And it seems like that would be a very nice fix if technically possible, Anne, because the completion rate on the arrest witnessed by is greater than 90%. So if it was witnessed by none, then you eliminate the date and time cardiac arrest data field requirement. That would be a very elegant fix.
And I know we do this in the validation rules for some other, I can't remember if we do it for cardiac arrest, I think we do. But I know Batsel's on the line and she's the one that runs more complicated analysis. Validation rules can have a lot of little itty bitty things. It can get really complicated when you do it in another system. So Batsel, do you think that's possible to do like an exclusion for that being completed if arrest witnessed by is none? So it's and prior to EMS arrival, so that we know that no one witnessed it, essentially is what the EMS agency is telling us.
Yeah, we can do that.
Yeah, I believe that's how I have mine set up.
I see this getting very complicated very quick.
I think maybe what we can do is go back up to the elements above and kind of look to see, I think maybe just see, is there a friendly amendment to strike arrest as therapeutic hypothermia? Kind of just do the 3 elements one at a time.
Yeah, we can go.
Just try to.
Maybe we should walk through them line by line, and I think it sounds like the other friendly amendment would be recommended on the column next to recommended for PEEP. Have a column that would say require if, only if, and then we can fill in a criteria for that. Does that make sense? So we'll use cardiac, or let's use the one we just talked about as an example. It was 14, E-arrest 14. So it would be required, yes, recommended, so PEEP. And then the next column over would be required only if witnessed arrest. A E-arrest 04 it's completed. That doable?
Okay, that's
You want me to share? You want me to share? I have the-
And I think also you should make it, I realize that they should be filling it out as witnessed if it's cardiac arrest after EMS arrival, but just in case they missed that one, I think that should always be included. If you have a cardiac arrest after EMS arrival, even if they accidentally don't fill in witness by, I think they should need to, that's my personal opinion. You should know it.
All right, so with that kind of formatting in mind, if we can look to do that, let's go through line by line and make sure everyone's comfortable with this. And then we will take all of these suggestions in column F and G as friendly amendment, unless there's significant discussion, in which case we'll vote on that separately. I'm very sorry, my eyes are not that good. I can't read. There we go. I think E-arrest 01, cardiac arrest. That's pretty straightforward. Any discussion on changes for that one? E-arrest 02, cardiac arrest etiology required. Any discussion on that one? Required, yes. Required, yes. Next up, I'm going to go through these fast, so please speak quickly if you have an opinion. E-arrest 03, resuscitation attempted by EMS. If it is required, yes. E-arrest 04, witness by required, yes. AED use prior to arrival, required, yes. Type of CPR provided by EMS, required, yes. Therapeutic hypothermia, optional, no. First monitored arrest rhythm of patient, required, yes. Date and time of cardiac arrest, required, yes. Only if required if witnessed arrest, perfect.
I think it's E-arrest.
Oh, I'm sorry.
It's equal to none.
Let me go back just so I don't get confused. E-arrest 12, any ROSC / sustained ROSC, I believe would be required, yes. I apologize for that. Skipping EREST 14. So required, yes. And Dr. Hannon, you had something about G.
Yeah, it should be required if it's witnessed arrest and e-arrest is equal to, not equal to none, right? Because if none is there, that should
I
be
think
none.
there's the value, just in case you want to put this in here, is if it's not equal to not witnessed, is actually the.
Yeah.
That's not the whole negative.
And you can put the not witnessed in little single quotes. Yeah, but.
Everybody comfortable with that? Yeah, we can fine tune that offline, I think. EREST 15, date and time, resuscitation discontinued, required, recommended, yes.
Yeah.
EREST 16, reason CPR discontinued, required, yes. Cardiac rhythm on arrival at destination, required, yes. End of cardiac arrest event. I'm sorry, just a question before we do this. Is this a time? I just don't know this data set.
I think it's the outcome is what it's asking, like termination.
It's like ROSC in ED, ROSC in field, died in field. Yeah.
Okay, perfect. Thank you. So with that clarification, required, yes. Date and time, initial CPR. Required, recommended, optional. I think our discussion, if I'm summarizing, is to include this as yes.
Yep.
Without any ifs. All right. Who first initiated TPR? Required, yes.
Yes.
Who first applied the AED? Required, yes.
Hmm.
Who first defibrillated the patient? Required, yes. The bottom elements, of course, would all be no, unless you guys want to talk about STEMI triage criteria, which I would encourage no also. All right, make sure we give folks time to think and discuss about that. Thoughts, comments, questions, concerns? All right, we'll call for a vote then. What I have is a motion to approve this table with friendly amendments as noted in columns F and G. All those in favor, please say aye.
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 Any opposed, please say nay. Any who wish to abstain, please say aye. Thank you very much. That agenda item passes. Next up on the agenda, discussion of data sharing agreements between trauma centers. Kristen.
Hi, my name's Christina Kupanoff. I am the Trauma Research Director at St. Joe's Hospital Medical Center. I'm joined today by Dr. Kravitz from Valleywide, Erica White, research nurse. My counterpart at Chandler Regional Hospital, Melissa Kovac, our Trauma Medical Director, Dr. Jordan Weinberg, and
I'm waiting for her to come underneath one of the green lighted tiles for the microphone.
On the ceiling, right?
Okay.
There's.
Thank you.
All right, so now plays a. So I come with a fancy queen, just introduced, and I'm here today to, along with our team, propose a trauma registry statewide data sharing plan. As you know, I'll just give you a little bit of background. As you may or may not know, the level 1 trauma centers are required to conduct research and publish our research to maintain our level 1 accreditation status. Because of the number of trauma centers we have here in the state, really nobody has a high volume, right? So we're trying to do our research using our own registry with a relatively smaller sample compared to, you know, other states. So the way that we're working now is kind of in silos. So I use our registry. I work with our physicians, our nurses, our faculty members, and come up with our own research ideas. And we don't really have a very easy way to share our data with other centers. Really, the impact to research is that it really forces us to stay with topics that we have plenty of. So for example, yesterday, we were in a discussion with Valleywise, and the idea of comorbidities with cirrhosis came up. And, you know, they looked at their registry, we looked at our registry, and really neither of us had enough patients in our registry to really do a solid study on, you know, to study cirrhosis. And we want to give our medical learners, our medical residents in our, you know, surgery residency program, and our students an opportunity to build their CVs, to present at national conferences. And, you know, we want to put our best foot forward. So what we, you know, we've been talking, and what we think is that if we can come together and work in a collaborative way, as opposed to kind of working in silos, we think we can conduct better research, and we think that all of our centers will benefit. So that's what we're wanted to come to propose today. The way that we are proposing to do this is to have a statewide umbrella IRB. So an umbrella IRB would allow, it would keep an open IRB that is approved for any trauma patient outcomes research. And the centers could opt into being part of this umbrella. And when we provide our registry data to the state could combine it and share it among the center to agree to participate. This is different than me going straight to the state on my own, because we're asking for PHI. So I might want to do a study on motor vehicle accidents, and maybe cirrhosis is a comorbidity. I might need each center to do some chart review. So we are asking for PHI. Anybody involved would still maintain their research requirements, or city requirements, as mandated by each hospital under their own IRB. And the templates that we're using to process, it's basically mimicked after the umbrella process that we have at St. Joe's Hospital now. How am I doing? Question? Is that clear? Yeah.
Good morning. Thank you for allowing us to present this. My name is Jordan Weinberg. For those of you who don't know me, I'm the trauma director at St. Joseph's Hospital, but I'm really speaking here to you today as the chair of the Arizona Committee on Trauma of the American College of Surgeons and the president-elect of the Arizona Trauma Association. I just wanted to share that I've shared this plan with all of the level 1 trauma directors in the state, and they're all on board. So this plan has the full support of all of our level 1 trauma centers. Thank you.
All right, thank you guys. Discussion?
Dr. Gaither, this is Garth Gamer. This model has been somewhat successful with the Phoenix Stroke Center Coalition, but this has the added twist of using data that would be reported to a state entity. So, I wholly support the concept. It certainly makes a lot of sense. But of course, the state would have to be behind this to allow it to happen. Thank you.
Thanks, Dr. Gamer. Other questions, comments? I do have a very simple question. Who's going to pay for this? And this is a lot of work. You're suggesting that, and this is me as a researcher, you're suggesting that the Arizona Department of Health Services serve as the IRB for any trauma program, research project in the state. That's a huge job. So I'm purely asking. I don't know the answer.
The way I see it, so a few years ago, St. Joe's went to the state, and we used the state IRB to propose a project, and it was approved, and we received data and conducted our project. So it seems that the service is there. The oversight of an umbrella is, at least in our experience at St. Joe's, is substantially less than an oversight of a full IRB on each specific project. So the way the umbrella works is any trauma patient outcomes project. And so the research question will be allowing for the inclusion of patient demographics, injury characteristics, treatments, and outcomes with a long list of variables. So if I propose a project
sub-projects under this umbrella. It will be a one-page, usually a one-page overview of what the project is. And assuming that anything I'm asking for is supported by our overarching umbrella, then it would be approved. I think that my thought is the data set is really a data set that the state already has. So when we upload our quarterly data, every trauma center is uploading quarterly data. My guess is that data set is sitting there and is probably almost shareable as it is. I agree, nothing to do with that, but.
Can I ask a question? The data set that the state gets in ASTR is more of a public health database, data set. We don't get what you upload to NTDB. So I don't know if it's possible for, it goes directly to NTDB, not the departments. So I don't know if the data set that we get, which is in rule, would be, what you'd be looking for.
I think though that since we viewed the data set before from the state, it seems pretty robust.
We'd have to look at the data elements.
Right, we do Amber, and then I think maybe calling Carissa, because she oversees the data set, so she can speak to that. I think
I mean, I have a question about the overarching umbrella and being able to use data that's speaking from someone that works for Banner. I mean, the amount that I have to go through to get data from Banner is incredible, even when I work at Banner. So even though the trauma program folks might be somewhat on board with this, I don't know that getting a large hospital system to agree to give their data that could be used for marketing purposes or other competitive things, that I don't know that you could get those folks to agree to that. So that would be my big question, is even though the trauma folks are on board, I mean, are these large multi-state hospital systems willing to just give their data to other research groups? And I highly doubt that, but that would be my guess.
So we are successful. It's very cumbersome, but we are successful. And so if I want to partner with Chandler or Valleywise, if I go to our IRB, we do have a process, and there are agreements, and there's definitely a process. Yes. But I am currently able to share, to partner with another trauma center and receive data. And, obviously when I receive the data, I need to be responsible with it. And we publish in journals, and we, on our IRB submission, we tell the IRB what we will and will not do with the data set. So definitely we, plan to be respectful of that. But so currently we do share data.
Yeah, but on a limited case by case basis, not an overarching.
Yeah, and this is Tiffany, and we do too, so.
Thank you, Tiffany. I'd like to next go to Carissa for some technical support or information on the DHS side.
Yeah, I had a few questions or comments, I guess. So the first thing would be, we have a lot of the NTDB data elements. There's only a few things that are different. Yeah, but that being said, I also noticed your dates you're looking at are 2014 to 2023. So between 2014 and 2015, we went from ICD-9 to ICD-10 codes. And so the data looks different, which is not the end of the world, but I would suggest maybe starting at 2015, that being if this gets approved and going forward. But that's just something I noticed is when people look for data that far back, they kind of it makes it difficult to use the different codes. Also, so we can, in theory, pull all of this data, but it's not going to be in one easy Excel sheet. It would be different reports and things like that. Trauma One that doesn't really have the capability of just exporting it all in a usable format. It would be different reports and things like that. So yeah, all that being said, if this all gets approved, we can do it, but it's not just one easy file that we could easily distribute out to everyone that's participating. It would be multiple files and things like that.
Carissa, I just want to add one more thing to what you said, is that our past experience with data sharing is that we usually, because of the HIPAA minimum data sharing requirement, we usually approve the request, but it has to be limited to the project. So it's not that your project wants to do one thing, but you are asking for all the data elements from the registry.
I'd imagine it may work a little better if all of the trauma centers are wanting to work on a project to develop a project idea and outline and then bring it to us. And so then we know which data and elements you need, because as Vatsal said, anything we've approved in the past through our own IRB and everything is you don't just give everything. It's what do you actually need to accomplish your research project and things like that.
Right.
I think that for us and for our experience a few years ago when we came to the state, so we did a lot of work to come to the state and go through the IRB. They did a lot of work to supply what we had asked for. And in the end, our project was not presentable. We couldn't submit it or publish it because we didn't ask for enough variable. And then we couldn't write a proper manuscript. So the ability to have a full data set, and so that we can really analyze different comorbidities, different patient population is really important.
Hi, I'm Melissa Kovacs. I'm a statistician at Chandler. I just wanted to add to Carissa's point. Thank you for pointing out that I realize this data can be messy, but so we already, as a participating trauma center, can have access to the national trauma data at this level, and we look at it and we publish on it, and it does come in. I think, Carissa, similar to what you're saying, it comes in as a data lake and we pick apart different pieces and different files and have to reformat. But I think my point is that would be okay, Carissa, because statisticians, we can put this all together and kind of create a data set that we would need at the project level to look at each time we're doing a project.
Thank you. Other questions, comments? I have a list of questions, but I have so many questions. I'm going to apologize. This is going to get way into the weeds, but I think it's important. My first question is, why do you need protected health information? The biggest risk of any study that looks at retrospective data is the disclosure of protected health information accidentally. I don't know of any PHI data points that are required to publish retrospective stuff.
The PHI would not be required, but because we're, as trauma centers, we're basically mining this registry for our publications every year. So, 40 years ago, there were thousands and thousands fewer publications. So any idea was almost an easy idea that had not been done or not been published before. Now, years and years later, every trauma center in the nation is really mining the same database for research questions. So coming up with these research questions just out of the variables that are handed over to the state is tougher and tougher. So most of the studies that we publish, and I think I can speak for Chandler and Valley, they really do involve chart review. And if we can't do the chart review, so like on our cirrhosis patients, if we can't go in and look up other variables in our EMR on those patients, then we are probably not going to be able to add new research to the field. Anybody?
Yeah, I
don't
have
yeah, go ahead. Sorry.
Point out that so whenever we're database studies are always limited by what's in the database. The strength of single institution studies is that every trauma center does this, is they'll pull the cohort out of the registry, but then they go to the EMR for all the granular details. For example, if you were doing a study of pre-injury statin use, well, that's not in the registry, but it's going to be in your chart because you'll have the whole medication. So the idea here is really to create a much bigger data set, so a single institution can be statewide, but then give each institution the ability to take their set of patients. Let's say we want to look at pre-injury statin use for BTE outcome, and everybody can take the list from the state data set of their patient and look up in their registry and actually fill in that data column of pre-injury statin use, yes or no. And then we've got some pretty powerful data. So we would never view the PHI beyond that, just to link.
So you would be asking institutions to go in and pull data points that are new and currently not defined in our current data set retrospectively.
If they wanted to participate in the study, yes, exactly. We do chart
And you'd ask
review.
the DHS to combine those data sets together and provide them to you?
No, what we were, what we were proposing is a platform such as like RedCap. So currently St. Joe's uses RedCap, and all of our research studies are the database, their data are housed in RedCap. And then the person doing the chart review logs into RedCap, logs into to our EMR and does the chart review and enters it directly. The state would not be asked to do any chart review. The state is only asked to help us combine files from each level 1 center and share it.
Dr. Rice?
I just have another question, and this maybe is more of a bureau question, but just historically, I don't recall the DHS ever really being involved in administrating research data. Public health data, yes, but the administration of research data, I don't really recall the DHS ever being involved in that, or that being really a purview of the DHS. I guess that's another question I have.
So part of that, there's the 2 different data sets. The AZ Peers is very much public health initiatives only, is the only time. So we get a lot of research requests for AZ Peers data, and that data is not based on statute, it's protected. So we can only share AZ Peers if it's for public health initiative. ASTR is different. There's some publicly available variables, and so that is a different data set that we do get periodically on research requests, which that data is correct.
But this would kind of fall outside of that. This would ask the DHS to create a essentially publicly available research data set.
That's not publicly available.
Well, any trauma center could request it, and we're asking them to. I don't know. I think the hospital systems would be unlikely to give up protected health information on an unlimited basis for.
Well, each center will opt into any study. So if I'm going to propose my cirrhosis study, then each center has the can opt in or opt out.
Or can't they already do that and provide their data?
With a lot of very cumbersome. Extremely cumbersome.
That actually gets to my next question. And again, I apologize for getting into the weeds, but I think it's necessary. Every research study that we do requires 2 written agreements, reliance agreement. So your facility has to rely on the DHS IRB, and it requires a data use agreement. Who in this setting is going to manage all of those written contracts for each study?
So for the way the umbrella works at St. Joe, we have those agreements are in place for the overall umbrella, and new studies can be added without additional agreements.
I think I'd push back a little bit. I don't think you could request additional data that's not already included under a data use agreement. You can't go back and ask for, was there statin use?
Right.
Unless it's included in your original data use agreement.
Correct. Anything on the original data use agreement, any variable for any study will be included. And so statin use would be a pre-hospital medication. Anything that is added, anything in any element in any study will be listed on the overall umbrella.
So in your mind, you would have a blanket access to any patient's medical record that's in the trauma data set.
If it is,
If each institution would have that on their own, it wouldn't be something cross. Like I wouldn't start looking at banner charts. That would be owned still by Banner University, for example.
But then in your example, BUMCP would go into their patient chart, take patient data out of their chart, enter it into a shared data set without asking the patients, without asking anybody else for any approvals. On any question, let's take that to an extreme where now we're talking about pregnancy. All right, you're going to ask, was an individual pregnant at the time that they arrived at the trauma center? Probably already there, but now we're going to go back in there and look for pregnancy tests and all of the medical charts.
Yeah. I mean, we do that now. But on single institution basis, right? IRB doesn't have any problems with that.
Right. I think the difference is that you get approval by that IRB for that study.
So, well, I mean, we don't. We have, for all retrospective trauma studies, we have a blanket IRB that covers all of them. Still have to submit the individual study proposal. So if I wanted to look at something related to pregnancy, we would submit that, but it's a much different, it's not starting from scratch every time with the IRB. It's sort of a quick review where they look at it and make sure it meets the spirit of the original umbrella proposal. We have that for trauma. We have that for neurosurgical outcomes. And it seems we've been doing it for years and it works really well. The IRB still is looking at each study, but
like our IRB would, not every IRB for every hospital would be looking at each study. Your single institution, which has a very streamlined approach to allowing you to do retrospective research, would be the one approving you using data from all across the state. So you're not getting approval from all the other centers for any individual study. You're only getting approval from your individual center to do study on other centers' data without them approving the study specifically.
But the studies, the centers would opt in. They don't have to opt into the study.
I guess I'm just confused why that's not necessary because it's already a common practice, right? They opt into a study, you enter into data sharing or data use agreement. You have a reliance agreement for one IRB or the other, and then you can do research. I guess I just don't understand why the state needs to be involved in collecting and administrating this data.
Thanks. Other comments?
Yeah, you're right. We could do this on our own without the state database. The idea being centralizing the IRB process to the state would facilitate this by quite a bit. Otherwise, we would be always dealing with, we've got 10 centers that want to do a study. We've got 10 different IRBs, potentially more.
Mm-hmm. Yeah. Those are the hoops we jump through every day. One more purely comment from me, and then I'm happy to call for a vote or whatever we need to do. This is just a discussion. There we go. So I reached out to my trauma center director. They didn't support this. So I wonder if you have any documentation about your comment. I'm from Tucson, the University of Arizona. I talked with Bilal and Andy. Both of them said they thought this was not necessary. So I'm wondering if you have any documentation about the entire state supporting this, because if this is something the entire state supports, I think that's very important to consider.
And maybe I could, from a state perspective, kind of two pieces. Number one, we have an HSRB, which is essentially the state IRB. It's extremely limited capacity and resources. And I think we've had Rob Broken speeches because she's been a member of that for many years. But the main needs for that are no longer with the department. So the ability to do that type of work, I don't know that there is the capacity at a state level currently. The other concern kind of piggybacks a little bit on what Josh was saying is, I think in order for the Bureau to do this, we want to make sure that each state had an opportunity anonymously to kind of opt in or opt out, just to make sure that there was no kind of feeling this public pressure to do this. And so I think we would want to probably figure out a way to do some type of anonymous survey and figure out who the right person is for each facility to ensure that we are kind of capturing whether or not this is general agreement. I think it would be hard to do this for only a subset of the trauma centers. It would have to be kind of all or none who want to do this in order to take on a project like this, just as the way we kind of administer programs.
Yeah, I mean, I have an email chain as far as Andy. Maybe I did not receive a email from him, so I overlooked that, I guess. But yeah, I mean, I could produce that.
Yeah, no, I think then it's not a big deal.
Yeah, no, I
I'm
understand.
simply bringing it up because I think if I were to see this move forward, I agree with Dr. Bradley. I think we need really a cost and legal analysis from the state to say this is something we can or can't do. And then we need the support of all the trauma centers. The feedback from our trauma center group, to be frank, was we already have this. I don't know why we need it. Yeah, I do a lot of research. That's 80% of my job. And I have an IRB for every single project I do. I know it's a pain in the butt, but it keeps my patients safe. It ensures that everything I do is properly documented. I do a lot of it. So this is my personal opinion, not as the chair.
And I think from a, this is not a voting item, really just a special piece. I think the piece that we can take forward from the Bureau is if a group would like to look into proceeding this, number one, what is the capacity and the capacity of possible have a centralized IRB do this work at the state level, number one, and then number two, figuring out a way to query the trauma centers anonymously to kind of gather the interest of participating, just because we want to make sure that there really is a support against who want to do this. We support the work that's helping us support the trauma system. Rockpool does a lot of work, and we've made a lot of adjustments to our trauma dashboard data visualization regarding trauma based on feedback from staff. So a lot of the data, like we have a school fall dashboards that we added based on feedback from staff. And so we look to kind of continue to create those data sets to address any questions that come up in regards to the trauma data. We absolutely support trying to improve the system, but I think the question is making sure that there be kind of uniform interest, number one, and then two, capacity for the one.
Discussion?
One question, would you also be looking at different level of data, like level 3 data?
At this time, we were proposing level 1 data. We'd be open to it, 'cause that's a great feeder system into, for transport type research studies. It's great to have that, but just starting with level 1 is, I think, it's big enough. Ask.
All right, thank you. Let's move on the agenda. Next item up, discuss reporting fentanyl use ingestion as part of ASPR.
Yes, I can kind of cover this just to come up, and I believe our Ariella is on the line as well. I think everyone in the committee and attendance is aware of the opioid crisis, and really when you look at what the opioid is that most individuals are using, most of the time it is fentanyl. And so currently, when we look at the data that's reported regarding potential drug use in our data set, we don't have fentanyl is not required one, so we can't update the ASTR data elements if that is not that we have the ability to update. But we can certainly encourage the reporting of those data elements. I think when you look at the illicit drug use, especially with fentanyl, how often that is involved with a lot of our trauma patients, and looking to see how that affects that. So we just want to continue to came up with FAB. There was a report about just encouraging that as well as just bringing that forward to our different data studies, trying to collect that data. I believe that there is some legislation that is out there as well to potentially make a fentanyl a mandate sort of a urine drug screen when the urine drug screens have changed. Most centers now it's two separate orders. You have your standard drug screen and then a fentanyl screen, and so the fentanyl is not practiced when entities order just the standard UTF. And so just really more of a discussion about what we feel is the importance of collecting this data as that has a significant impact on our trauma patient.
All right, discussion, comments, questions, including fentanyl in the trauma registry, not EMS registry, important.
And I think it's just to add to the discussion, when it was brought up at staff, one of the questions was, well, does it make a difference? And the answer is it does in terms of the options for treatment. So if you look at kind of the next step for patients, if you have the opportunity, sometimes when a patient is in the setting where they start to have withdrawal symptoms, this is where they may actually have the opportunity to wanting to start medication treatment and start for treatments for their substance use disorder. So really, if you don't identify the patient, you're not going to identify. Many of these patients end up losing AMA because they go into withdrawal and they're not getting kind of the appropriate treatment. So if you test for it, you recognize it, it gives you the ability to then actually affect topic change for the patient. That was some of the discussion that when we discussed this with staff. So we just wanted to bring it back to this group as well. Really not something we can add as a requirement to ASTR, but just wanted to see if there's any other sponsor input from anyone in the committee or online or in the room.
I just wanted to clarify too that even though we can't add it as a new individual element, the substance use data set the pick list has been updated. So instead of just having opioid, the registrars do now have an option for fentanyl so that they can pick that and it can be captured somewhere in the registry.
Thank you, Krista.
Thanks, Carissa. Any other comments? This seems like a reasonable data point to include. It also helps with demographics, working out your cause of injury, all that type of stuff. Thoughts? All right. We'll move on to the next discussion item, discuss falls and ATV dashboard, the data visualization page. Thoughtful.
So we just want to share kind of this is some of our data that is put together by Voxel and her team, and really wanted to point out just kind of the significant change that we've undergone in the last couple of years. We used to put out an annual PDF state trauma annual report, and it was really that fixed data. We couldn't change it or update that. Each year we would produce the report, we would take it to staff to approve, and usually get great feedback. So we have, I had really no part of this work. This is all Voxel, her team have done the work to put together these dashboards, and you can see how you can actually adjust this by a number of different criteria. So you can adjust based on your patient ages, which you can just click on that one. You can see all age groups 0 to 17, especially for the off-road one. We've got a number of elements. If you want to go to trauma injuries by years, it will have it here. Oh. Voxel, are you available, Voxel?
So yeah, I was here. I was talking, but I didn't realize I was on mute.
All right.
And then you started, and then I realized, you're like, oh my God.
So I was trying to cover for you, but go ahead on. We'll hand it over to the experts.
Yeah, no worries. You can go ahead, Dr. Gabelli.
Okay. All right. So you see this is kind of just an overall volume of trauma centers that you go to falls. This is one that really came out as a request from staff as well as this committee is looking at a lot of the fall data. And so excited to see some of this additional information here. When you look at the fall, it's opening slowly. So you can see here we have for year 2022 under level of fall, we have fall to height and then ground level fall. So that was one of the things, the requests we had gotten from staff. So as opposed to waiting an entire year for our next annual report, we can actually, since our last staff meeting in January, also was able to put this together, start isolating data for ground level falls versus fall to height. We also included hip injuries. That was another request that came from the committee as well, as looking at falls with hip injury versus all falls. And also patient age groups. So we can look at pediatric and then greater than 65. So if you look at greater than 65, falls hip injury, you can scroll down on the page a little bit. And we've got deaths and outcomes there. And we've got the rates, 100,000 population. And then the gender demographic based on age as well. And if you want to scroll back up to the age and just do all falls for hip injuries, do all falls, and then patient population, will look at pediatric, so 0 to 17. And then you can see here, and obviously the vast majority go home. So you have some of the data shifts and adjust based on this. And then you look at the different age groups broken down there as well. So quite a bit of information that is new in this data set. So a big thank you to Voxel. Really, honestly, this was the request that came. If you had a severe fall, the next tab, this was some of the requests we had got from staff and TEPI. So if you look at this, you can view, if you go to 0 to 17, go to all age group. And so we've got admitted to the hospital, then to ICU, the length of stay. If there's associated head injury with these injuries as well, we've got the age breakdown. You can see there when you look at all age groups, the variability, and then we can see the deaths and other outcomes, as well as suspected alcohol or drug use involved. If you scroll up a little bit, back again, if you say, okay, we want to go to just geriatrics, say 65 and above, you see a shift there in some of those variables. But still see alcohol as number one substance use involved, but a smaller percent in all age groups. And then you see different percentages for medicalized use. So really, if you, as we won't go through all of this in detail, but wanted to just highlight some of the work that Boston has put together just since January. So one of the things that we're really excited to have these new dashboards to, as opposed to waiting a whole year to take feedback from the committee and make those adjustments, we can take this and then make the adjustments and set out new data that anyone is able to go to these dashboards this year.
Thank you. Questions, comments? I'll add my comments. Thank you guys very much. It's extremely helpful data. We just pulled this last week to support some highway traffic safety injury prevention work. So very important, valuable data that we use at least in Southern Arizona on a regional level. So thank you.
And Dr. Baker, I just want to add one thing. What you are seeing on the false dashboard, so the first tab is from the hospital discharge database in order to give us the overall picture of the falls, because in trauma registry, we do not collect each and every falls, in just so that we can understand the magnitude of falls in Arizona. What I have done is that the first tab is falls related discharge is from hospital discharge database. And it says on the top, number of falls related discharges from hospital discharge database. And then the second, severe falls. But when I say severe fall, that means if they go to the trauma center. So it is not related to the injury severity score or anything, but it is from state trauma registry. So this dashboard gives you, the overall magnitude in the state of Arizona and then what's happening in the trauma center. So now moving forward, like that is what I'm thinking that, whenever this is applicable and we would like to also see the bigger picture for any particular mechanism of injury, then this is the way to go, is that, we involve both falls hospital discharge database and trauma registry.
Thank you, Vatsal. Any other discussion before we move to the last agenda item? We're running short on time. All right, let's move ahead then. Discussion on implementing Article 9, AZ Peers reporting requirements. Dr. Bradley?
I'm not sure, Anne, were you up for this one? I apologize, we don't have the name on this, and I was not prepared to report on this one.
I'm not sure if I am, but I can certainly discuss it. I wanted to put in the chat a PDF that should be relevant. Let me just, oops, there we go. Did it send? Okay. So Article 9, reporting requirements. For my part, I think I'll just take a moment to talk about where you can find this reference tool. And then also, although it was created actually a couple of years ago, it was created with 3.5 in mind. I believe all of the rule requirements on the left still match the language in the rule. If not, I will update it. But basically, this is a crosswalk that was created based off the new rule language requiring reporting for CON holders, ground ambulances, and then crosswalking the relevant AZ Peers data elements that we would consider as included. The reason the rule is not as specific, I can't say the word, as, like, for example, some that the committee is familiar with, like trauma, is because, as you guys probably know, our database has updates to its data set, usually major ones every 4 or 5 years and minor ones every couple years. And we're not going to probably be able to write the rules that often, and we don't want to have stuff that is set in stone, specific data elements that then don't even exist and therefore kind of create a burden. So we have a generic but specific rule language on the left and an example of what it maps over to as specific data elements. On the AZ Peers information page, the ADHS one, there is a breakdown of exactly what these elements, numbers are and a bunch of additional information. And I don't know where this will live later, but right now it's on the active rulemaking page. If you go under EMS ground ambulances, it is, I'm going to look at the date that it's on, and it just says crosswalk. It's at that link, I realize also, but I'll put in the page link too for now, just to, because otherwise it's hard to find. And then as far as just general compliance. There's another part in the reporting statute that says, you know, in a department approved format, and there's a timeliness piece where all EPCRs should be initially submitted within 48 hours from unit notified by dispatch date time. The national standard is 24, if that makes it seem a little less scary, but when we started this rule writing like 5 years ago, we didn't have that guidance yet. So we kept it at 48 for now. So the initial report should be submitted within 48 hours, and then the agency can resubmit it to overwrite it later. But the time we'll be looking at is the initial created time. And as I said, the department approved format is essentially AZPRs in electronic format, and whatever the current NEMSIS standard is that we have adopted based on the data dictionary. I don't know if that gives enough information or if that's too much, but.
Thank you, Ann. Appreciate the information. Any questions for Ann? All right. In the interest of time, I'm going to go ahead and move forward to the call for agenda items for the next meeting. Please send those to Shelley. Her email is, of course, in the agenda, and those can be considered for the next meeting. Call to public. All right. Please note we have some upcoming events. You can see a long list of those there. I will not run through those. And note our next meeting will be July 18th. Right here at 9 a.m. I look forward to seeing you all then, and we will adjourn this meeting. Thank you, everyone.
Thank you.
Goodbye.
Thanks, everyone.
Thank you.